nghiệm thực tiễn có giá trị trong chẩn đoán và đánh giá về bệnh lý tim mạch. Với sự đồng hành của các chuyên gia giàu kinh nghiệm, hy vọng phiên hội thảo chiều nay sẽ tiếp tục mang đến những góc nhìn mới, những trao đổi chuyên môn sâu sắc và những giá trị thiết thực cho công tác khám chữa bệnh. Và xin kính mời bác sĩ Nguyễn Thị Minh Lý sẽ trở lại vị trí để tiếp tục điều hành phiên hội thảo chiều nay. Xin trân trọng kính mời.
Bác sĩ mình sẽ quay trở lại hội trường, chúng ta sẽ bắt đầu cái phiên chiều nay luôn ạ. Thì sẽ có một số thay đổi trong cái chương trình và chúng ta sẽ cố gắng đẩy các bài có báo cáo viên là các giáo sư trước, sau đó chúng ta sẽ có làm các hands on rồi chúng ta mới nghỉ giải lao. Thì sẽ theo cái thực tế chương trình để sẽ diễn ra thì để các anh chị được tối ưu hóa nhất cái thời gian học tập của chúng ta. Thì bài đầu tiên trong buổi chiều hôm nay thì chiều hôm nay chúng ta sẽ chuyên về van 3 lá. Sáng hôm nay chúng ta đã về làm van 2 lá rồi. Thì bài đầu tiên chị xin mời Thạc sĩ bác sĩ nội trú Trần Hồng Quân sẽ có bài chia sẻ về đánh giá van 3 lá trong thăm khám thường quy 2D và 3D thành ngực. Bác sĩ Quân sẽ có 30 phút để báo cáo ạ. Xin mời bác sĩ Quân ạ.
Good afternoon, everybody. Today I'm going to talk to you about tricuspid regurgitation and how the application of 2D and 3D technique on TTE imaging can help you evaluate tricuspid regurgitation. On my talk, I will focus on 2 points. Why do we look at the tricuspid valve now? And the second part is going to be how we approach the tricuspid valve with 2D and 3D imaging. So in the 2020 and 2021, we have ESC and ACC/AHA guideline. We have 200, 300 page. We have about 2.5 page about tricuspid regurgitation. It reflects somewhat of the part we forgot about. But in the 2025, we have an update again with 6 page. So we double the level of knowledge we have. We have a few new points. We think we have a few new points about tricuspid. We have more to talk about this valve now. So a few things I think on my practice, I might have changed my point of view over the last couple years. The first is that the tricuspid regurgitation and prognosis. A few meta-analyses have looked at tricuspid regurgitation from different valve left heart disease, CS, be it PAH. We have different level and different percentage of TR on these patients. But what seems to be the trend is that the more severe the TR get, the moderate, the severe, the worse the patient gonna get. So seems like the tricuspid valve have its own role in the prognosis of the patient. Well, another point is that in the past, we seem to think that we fix the left side problem, the tricuspid regurgitation gonna go away. But see, from research we have also seems to realize that it's not gonna go away. Sometimes TR develop after successful mitral or left side valve disease. In some of these cases, the rate could be like up to 6%. And the predictor is like preoperative AF and the worst ejection fraction before operation. And one thing worth noting is that the TR start to going up as the TA or RA diameter or area start, dilating. But, it's only moderate. But as the RA and TA didn't get any much larger, but the TR keep getting worse on the 15 years, even though the RA and the TA diameter didn't significantly enlarge, the TR gets significantly worse. So there are other things that could make the TR worse over time, and we have to look over for these things. Also, the other thing that we usually do with our center is a balloon mitral valvotomy. We usually also think that if we open the mitral valve, the PA pressure gonna went down and the TR gonna regress. But some of the research point out that up to 88% will not experience any regression of TR at all. Recent research also showed that with very good result, some patients could never regress their TR at all. Those are the patients that is older here, say 30 years old, and they have more atrial fibrillation. A third of them might get atrial fibrillation. So this is what you think about when you think about your patient that go into your clinic, 50, 60-year-old atrial fibrillation. They have suboptimal valve for the procedure, because in this case they have after the procedure the valve area increased significantly from almost under 1 centimeter to could be sometimes 2.2, 2.5 centimeter. It was, I say, very optimal result. Most of the patient we have it didn't even get that level, but over the follow-up time, they experience no TR regression at all. So that's something when you think about when you send a patient to do valvotomy with severe TR. And also another thing that in time I changed my point of view is that in the past we think that regurgitation lesion, especially the right heart disease, you know, we think is more tolerated because of how elastic the right ventricle is. But I think the problem comes from the fact that we have the tendency to give the patient diuretic. If you have a right heart problems, if you have pulmonary regurgitation, tricuspid regurgitation, you usually give them diuretic. The symptom went away, and then you say it's tolerated. You probably should remain on medical treatment alone. We shouldn't touch the tricuspid regurgitation. But what we learned from all the research over the year is poor diuretic. That's by relieving of symptom doesn't improve mortality. And this is exactly why when the liver gave out, the renal gave out, you send the patient into surgery, and this would be very much in contradiction to the guideline, because your treatment doesn't affect on the mortality, and you should probably do something else, because the mortality for the operation of tricuspid regurgitation is at 12%. Let's compare that to MR. In this case, patient with MR went to surgery, their ejection fraction go as low as less than 30%. And you can see here that the mortality rate is actually only 7.6%. So still less than your well-tolerated lesion. So that should speak to you about something that maybe if the lesion was really well-tolerated, you send them in too late, or the lesion is not well-tolerated at all. So that's something to think about, right? So, and now we have more treatment modality and also a dedicated score for the isolated tricuspid valve surgery. Why do we need to think about this? Is if the patient is on low and intermediate tri score, your treatment likely to improve their outcome. But if they sleep through and they went to high tri score, unless you do a very successful procedure, otherwise you're going to make them very much worse. So this is something to think about. So that's why lately we try to approach the tricuspid regurgitation and by quantifying how the tricuspid regurgitation actually is doing. So this, according to guidelines, we have qualitative, semi-quantitative, and quantitative measure. I'm going to skip the right ventricular function part because it's probably on another part, another talk. So for the qualitative here, you can see on the left side, this valve is obviously fail segment and a very, very severe and big regurgitation force. Also, a second point is also likely the same as the MR, is that the jet shape and density. You usually look for a very dense and triangular late peaking for the severe tricuspid regurgitation. A friendly reminder that they have already done research on this. These are patients with severe tricuspid regurgitation. They went into the clinic. They will have invasive to determine whether they have pulmonary hypertension or not, and then they will determine if the patient also have pulmonary hypertension on echo. So the first group is the one who don't have pulmonary hypertension. The second one is the one who have both pulmonary hypertension on echo and on invasive maneuver. And the last one is the one who have pulmonary hypertension, but they don't show up on echo at all. Here you can see a very dense and late peaking triangular shape. Here you see a very small shape, and this doesn't look significant at all. But on the outcome, we actually see there's a patient who have actual pulmonary hypertension on invasive maneuver, but no sign of pulmonary hypertension on the echo. Is actually the one who do much worse. And for this patient, usually the one who has longer disease, they have higher right atrial pressure, and so they have the worst outcome. Another way you can do is vena contracta, but it's the same thing. Vena contracta assume this is a circular shape, but on the end fast, you can definitely see this was not a circular structure at all. This is anything but a circular structure. And depends on where you cut the line, it could be very different. But should we trust the VC then? The research has been done. If you take the cut point of 7 millimeter, if it's over 7 millimeter, usually it's in relation to prognosis, and you probably should do something about the tricuspid regurgitation. This is where 3D could come in. We could determine the 3D area of the VC on with the help of 3D imaging. PISA, again, PISA is the thing that in echo we talk either you are a PISA person or you are not, because we make even more assumption with PISA, because a lot of things went wrong when you determine the radius on how you get this continuous wave Doppler from the jet. A few of the pitfalls that you can see here is that the first is we assume that this is a hemisphere, but because of how the probe actually get the signal, some of the one who more diagonal to the probe actually got left out, and you don't ever get the true hemisphere. You have some of the smaller shape. Also, PISA tend to a fluctuation, especially for functional tricuspid regurgitation throughout the cardiac cycle. Also, the point is that the jet meet the planar of the tricuspid valve, and the planar could be flat. It could be, a bit of shadow shape or other shape. So it will make the radius evaluation less successful for you. Also, the shape is not a perfect hemisphere. So if you do explain through this, you see the diameter of the hemisphere could be very much different. So some research point out that maybe for PISA could be a bit less reliable than VC sometimes. I would say not all the time, but sometimes, because of how difficult we get the hemisphere. For the quantitative Doppler, you will same as the mitral valve, we will calculate the forward stroke volume through the LVOT, and then we could assume a shape of ellipse through the inflow of the right ventricular and the four-chamber view, and then we calculate the area of the TV annular, and from there we calculate the error and the regurgitation volume. So that's why the tricuspid annular is actually important. Here you can see this is a diagram of the tricuspid annular. The green one is anterior, this one is posterior, this septal, this is the figure. Usually what we measure is the purple, light purple here, but the largest we can measure is actually this one, from the anterior septal commissure to the posterior leaflet. And as you can see on the diagram here, this is what we measure, but this is the biggest one that we can actually measure. So in surgery, they will measure this one, and we will measure this one. That's why you will see a big difference on the criteria for the tricuspid annular in surgery and in our echo lab. This one is a research of day first. This one, they measure the big diameter that I'm talking about, the red one, with the cutoff of 70 millimeter. And they see that over follow-up, if every patient with the tricuspid annular diameter less or more than 70 millimeter have their tricuspid valve repair, they will get better NIHA and less TR over time, even though the mortality rate didn't differ. Another one is four-chamber tricuspid annular diameter with cutoff of 40. So, they almost double each other. But same thing, if you do, but still, if you take the cutoff of 40 millimeter and you fixed it, you'll get less MR and you get better result for the patient. The tricuspid on 2D echo, you have a few. This one is the RV inflow from the parasternal long axis. You want to tilt the probe downward a little bit. You will see, if you see the coronary sinus here, this one is the the anterior leaflet. If you see also the coronary sinus, usually you are cutting the septal leaflet. And if you don't see the coronary sinus, usually you are looking at the posterior one. On the short axis, you will sweep down from the RVOT to the LVOT. If you see only one singular leaflet, it's usually the anterior one. If you sweep down to the aortic valve, you're starting to see valve. Usually this one is anterior, this one is posterior. If you go to the LVOT, you can see the 3 leaflet here, with the yellow one is the septal leaflet. 4-chamber view or right ventricular focus view. If this one, you only sure about the septal leaflet, the other one could be anything. If you tilt it a little bit, if you see starting the LVOT, and you will know that you're actually cutting the anterior one, and if you see the coronary sinus, which we down below here, usually could be posterior one. But the thing about this is that this is percent. There's no way to tell that if you see this one is which. So on 2D, we have a lot of limitation on identifying the leaflet. So you can try and cut the end phase valve from the TTE. I see it visible in maybe half of the patient, I think. Could be helping you identify leaflet better. So how many leaflet actually the tricuspid valve have? Now we need 3 anatomical landmark, which the first one is the anterior septal commissura. The next one is the interventricular septum, and the last one is the anterior papillary muscle. So the septal leaflet is the one who attached to the septal leaflet, the anterior one is the one who lie above, anterior to the papillary muscle, and the posterior one is the one who lie posterior to the papillary muscle. So research have shown that most of the time VRI they have 3 leaflets, about 54%. Almost 1/3 of the left one is a type 3B, which means you have 4 leaflets, and 5 and above is around I think 2%. So this is on 3D echo. You can see this septum. This is the aortic valve up here. So you can see this is a septal leaflet. This one is a anterior leaflet, and the one here is the posterior leaflet. On NFAS view on T2D, you can see the papillary muscle here. So you can see this one is a septum, this one is a septal leaflet, this one is a posterior one, and we might have 2 anterior leaflet here. Sometimes you can get the image like this, and you can clearly see which valve is what, but this is not the norm. So on 3D, you can get 3 leaflet. Sometime on patient with congenital heart disease, it could be useful in identifying what valve you are looking at. As this one is some patient with transposition of great artery. So this is a patient with tricuspid, with bicuspid valve. You can see there's a raphe here, 2 valve fields and function as only 1 valve. This on a patient on who have ASD. So you can see that it's working as a bicuspid valve. So this one is a patient with quadcuspid valve. You can see 1, 2, 3, 4 here. So so this make the anatomy identifying on 2D even difficult, because we have so many combination of valve position and number of leaflet. Mechanism wise, you also look at this on 3D. This one is a patient with rheumatic heart disease, and this is a tricuspid valve. We can see the fist-mouth appearance, not the normal tricuspid valve that we usually see. This one is a vegetation on the posterior leaflet, also a reason that we can get TR on echo. So this is a prolapse of the posterior valve. You can see here the septum, the anterior, and the aorta, and you will see a wall impingement coming from the posterior leaflet. And you can see here it's a case of anterior prolapse of the tricuspid valve. This is prolapse section, this is aorta, this is the ventricular septum, the atrial septum. So CS is also something that we separate into its own category now, because the we need to know if the lead is actually have an effect on the function of the tricuspid valve. We have sometimes non-interfering and sometimes it could be adherent, could be impinging or entangled with the valve. Usually we have a lot of place where the lead can stay. It could be a commissure right in the middle or on the valve. This is the case where patient with severe tricuspid regurgitation, you could see the leaflet impinge on the posterior leaflet here, so it cannot coagulate on, and you see a big jet coming from the middle. This one is where the lead stay exactly in the middle of the tricuspid valve. It didn't affect the function of the valve at all. This one is stay in the commissure, and you can see somewhat of a separation here, but not much. So that's the end of my presentation. Thank you for your attention, and I would like any feedback if possible. Thank you very much.
Rất là đúng thời gian, và rõ ràng các anh chị và các bạn thấy là để mà đánh giá van 3 lá là nó đã khác hẳn với van 2 lá rồi, tức là cái hình ảnh nó không thể được rõ nét như van 2 lá đấy, ngay cả trên thành ngực và thực quản đấy. Thế nhưng mà chúng ta thấy rõ ràng là bây giờ cái van 3 lá là như là van bị bỏ quên. Tức trước đây thì chúng ta chỉ tập trung điều trị ở van tim trái thôi, nhưng mà bây giờ thì cái việc điều trị đó nó cũng không giúp cho bệnh nhân được tối ưu hóa được cái điều trị. Thế nên là chúng ta vẫn cần phải có những can thiệp vào van tim bên phải. Chính vì thế mà chúng ta sẽ cần phải có những cái biện pháp để tối ưu hóa hơn với cái hình ảnh chẩn đoán van 3 lá. Và để tiếp nối chương trình thì for the next lecture, I would like to invite Professor Raymond Wong to deliver a lecture about advanced diagnosis of tricuspid valve disease using 2D and 3D TEE. Please. Thank you.
Yeah. No, it's not showing. Okay. Yeah. So again, thank you so much for this opportunity for us to share some of our experiences with the local cardiology experts, and in particular the echo. I thought Dr. Tran's talk was really comprehensive, and it is actually by design so. Reasons because in tricuspid valve evaluation, I think transthoracic echo is still the mainstay. In transthoracic echo, your right ventricle is actually an anterior structure, so you can, in fact, you can actually get pretty good images for most part, unless the patient's hip is very obese. Now, transesophageal echo, on the other hand, is difficult. We only do transesophageal echo specifically for tricuspid regurgitation, only when we are trying to determine the candidacy of the patient, whether the patient may be a suitable candidate for a tricuspid valve intervention. Otherwise, we actually don't. So what I'm probably will share with you is it has been shared actually just now by Dr. Tran. I think we know that we learned a lot from Dr. Rebecca Han's work, and I think this is really the problem, isn't it? First we realized that the quadricuspid tricuspid valve is pretty common. It's about 30-40%, and then our textbook tricuspid valve is probably just about 50%. And it's not helping, right, when we are trying to decide where the regurgitation is, because you can actually see the difference between. Okay, so if there is a two septal leaflet over here, it's quite obvious, right? But when you have a two anterior and two posterior, are you going to give this A2 as P1 and P as P2? It's not always that obvious, and even when you're looking at the type 3A and type 3B, if you look at the configuration and the geometry of your tricuspid annulus, now it is saddle shaped, and I think if you pay attention to Dr. Tran's talk, I think he may have gone a little bit fast just now because there's so much information. You realize that as the patient developed atrial tricuspid regurgitation, functional regurgitation, right? The the mitral annulus actually does not get bigger in every dimension. In fact, it stretches itself out into the anterolateral. So it gets more and more and more distorted. And by the time the patient gets sent to our echo lab, for example, sent to me to do a transesophageal echo evaluation, it's not always easy to tell. And in many of these patients, the left atrium are pretty dilated as well. Some of them are giant. So your tricuspid valve become a very distant structure away from your esophagus. So on that note, I will share with you later on. In the end, it probably doesn't matter, because what we know is that any big gap, well, hopefully it's not too big, but any big gap between your septal and this one, this is where our tricuspid clip, which Professor Kong later will share with you, it gives us the best chance of a success for a tricuspid clip. Okay, so if the patient needs to go for surgical correction, it doesn't quite matter, right? And if the patient is not a candidate for clip, again, it doesn't quite matter. Although what we do is that we went through with our senior residents and our fellows, and then we engage in a very academic discussion as to what is what. Okay, so this is just the images from the transesophageal echo of the different configuration. As I mentioned earlier, this is what we see 50% of the time. So you have a very clear septal leaflet. That's the one which is right next to your right ventricle. And what we do is that by placing your aorta in the 5 o'clock, you always get this as anterior and this is posterior, and that actually helps, because if you don't put your aorta over here, you can actually get lost, right? It's just like getting lost in a very big shopping mall. So this is somewhat where you can actually see that there are two septal, and this thing is almost fused. So sometimes this one can be confused as a bicuspid tricuspid valve, but if you pay attention, there are actually two floppy, two leaflets here flapping away, and the rest and so on and so forth. So the one that makes no sense to me is F, where you can actually see that it's just a whole lot of the leaflet coming in. This is the type of cases that we usually may not want to proceed with the tricuspid clip, because it's just going to be each of the leaflets are just too small and narrow for your clip system to actually hold on to and clasp. So I actually think that this is going to be a short talk, and I'm probably just going to spend a bit more time here for all the technical difficulty that I sort of described. I know it sounds a bit disappointing, but this is something which I think it's I would like to share, and this is something that I've learned the most making use of the our tricuspid module. So number one is that this is a transesophageal. You got to go a little bit deep. So this is like a deep esophageal, not yet transgastric view. So if you do your mid esophageal view, just now you saw on the mitral valve, you get your apical four-chamber. I mean, sort of a four-chamber view. If you push a little bit down, you can get over here. So this is the inflow view. This is usually it's about 90 degrees. So you kind of dial, and then you get what is very similar to the focus view on the transthoracic echo. So when you do that, you are aligning yourself here straight down AP. So this is you're quite certain that this is A, this is P. All the more so when you actually see that there is the outflow tract, or sometimes you can actually see the aortic valve over there. So once you see that, you know that you're quite certain this is AP. And if you then turn on your X plane, you kind of like cut across here. So this is your septal lateral. This is septum because the left ventricle is over the other side, and that is the lateral, which is where your left atrial appendage might come over this side if you turn it around. Okay, so go a bit deep, deep esophageal, not yet transgastric. Get a pretty nice inflow sort of view. Make sure that you see the aorta over here, and then you turn on the X plane. Then you know where you are. So it's not actually 3D, but it's making use of the 3D principle. The next one is this. You can actually sometimes I think later on we might be able to show you. You can actually leave a marker to label it. This is P, this is A, and then later on when you turn around, it actually stays with you. And if you then expose, if you then expose more
just tilt it over, same, but turn over slightly to see the full view of your aorta. Then you are cutting right up here, A and P all the way. And when you do that, the other X plane is going to show you right up here, the septal and posterior, which also means that you turn the other way around, you're going to get AP, but this red line here is going to be anterior and septal. So I think X plane for me is more reliable. So this is another one. So you turn it around this way, going down here, you're going to get more of a anterior and septal leaflet. And this is the most important, because with respect to tricuspid clip, right, just for tricuspid clip, this is where we're going to clip. And you can see that you need this view, you need this patient to have a very clear transesophageal echo images. Again, if the left atrium is giant, the RV is a distant structure, we might not be able to see it. And for our own lab, that's one of the main reasons why we have to drop the patient from being considered for tricuspid clip, because you cannot see where you are. There's nothing to clip, right? There's nothing to clip because transesophageal echo is our eyes. Just now, again, I think the previous speaker have spoken about tricuspid annulus. This, from the point of view of tricuspid clip, this is really important because normal tricuspid annulus is about 28, 32. Sometimes we see 36, but 40 is about the upper limit. You will, if you scour through PubMed, you'll find people who clip 50 annulus, but I think usually 40 is the comfort zone. And tricuspid annulus, okay, this is not fair. It looks round, but it may not be round. It may be actually elongated this way out. Okay, so make sure that we measure the widest diameter. And I think while transesophageal echo is really useful if you have a clear image, but don't ignore the transthoracic echo for a reliable measurement of the widest diameter of your somewhat oval-shaped tricuspid annulus. And I think this is important because we are also beginning, maybe Prof. Kong can verify, we are also beginning to look at cases where there is a severe tricuspid regurgitation from the pacemaker lead. Okay, so as long as the leaflets are just being, I think that will be, yeah, over here. So if there is an adhesion, if there's a damage to the tricuspid leaflet, there's no clip again. But sometimes it is just there, and it is because it is a rough, and you have so it is sort of in a way and impinged to the side. So as long as you have a clear gap over the anterior and septal leaflet, you can actually still put the clip way down and then just hold it there. And then in that sense, you can either push the you can either maintain the lead all the way to the gap in between anterior and septal, or just sort of park it right in the middle. So it's still possible. So when we decide, when we do the transesophageal echo for the candidacy of tricuspid clip, these are something that we look out for. So again, if I may just summarize, we want to see atrial, septal and anterior gap. We don't mind seeing a septal and posterior gap, but pretty much everything else we at least for our centers, we do not offer a clip. And I think to just finish off, I think these are just some 2D images to supplement all that I mentioned. So if we then, let me see, I think this were already discussed. So in the interest of time, I may not want to go through again. I just want to say that the vena contracta as well as the PISA head is difficult. It's something that we look for. It's something that is repeatable, and on Rebecca Han's paper, you can actually see that if you have a vena contracta that's more than 7, it's kind of like quite reliable to diagnose severe, and more than 14 is massive. But the RV is a low pressure system, so you may not actually in the setting of severe TR, you may still not get a big color map. Okay, so not having a big color map does not rule out severe TR. Okay, and we know that the tricuspid PISA is not hemispheric, right? So you don't always get this kind of a very nice hemisphere. So what I'm trying to say is that the parameters are used. I believe I just put it up as shared by Dr. Tran. We still make use of all these numbers to guide us to decide when the patient should be considered for a tricuspid clip. But just know that I think if you have all the numbers, you are confident. If you don't have those numbers, don't but the patient has, say, cardiac cirrhosis, pedal edema, and high JVP, repeated admissions for fluid overload do not rule out a clinical severe TR just yet. Okay, and yeah, so we have gone through this. So okay, so you make my life easier. And this is just some rehash of what I think is worth trying, especially if you're going to embark on the tricuspid clipping program. Make use of the X-plane to decide where the severe TR might actually emanate from. And again, so this is yeah, anterior and septal. This is if you have if your entire severe TR concentrate on here and you have enough leaflet length, which I believe Professor Kong may share with you, this is where we have the highest opportunity, success rate to clip. So yeah, so I will stop here and I will welcome any questions from the audience.
Lectures. I think compared with mitral valve disease, tricuspid much more difficult and much more less familiar. Yes, because now we just beginning to learn from this, and I think that's why, because that seems complicated, but soon when we get familiar, it's much easier. But you have show us a very especially the two graph, the basic, yes, and the core to when we find the place to do the clip. And anh chị có ai có câu hỏi gì thì mình có thể hỏi các bác, nếu không thì chúng ta sẽ I think you have chị có hỏi không? We will move to your next lectures. You have one more lectures about echo guide in tricuspid valve intervention, and then after that we will have a question. Thank you. I would invite Professor William Kong for the next lectures. Thank you.
Sure. Okay, good afternoon. So we come back again to the afternoon sessions. I'm just going to quickly bring you through some of the imaging guiding for tricuspid valve procedure. As you know, the TRILLUMINATE study was published like 2 years ago for the TriClip outcome. Unfortunately, it does not improve survival. It only reduces hospitalization, improve patient NYHA status. But nevertheless, there's still some group of patients that will benefit from TriClip, especially those with a severe right heart failure and right ventricular overload. Okay. So I'm going to bring you through some of the repetitions of from the previous talk. Tricuspid valve anatomical feature. It has quite a large variability of the anatomy. Most of the time we see 3 leaflet, sometimes we see 4, and rarely we see 5 leaflet. And then the shapes is also non-planar, D-shape or sometimes elliptical annulus. And the leaflets is thin and also have fragile cord. And it's thinner than the mitral left leaflet for sure because on the right side of the heart, so lower pressure, so it's thinner. And making acoustic shadowing and tissue tear risk much higher. So when we do TriClip, do bear in mind that these are the limitations. So, and also it's an anterior location for the valve, far from the traditional TE probe position in the esophagus, leading to attenuations of the images. And then for large coaptation gaps of the tricuspid regurgitation, severe TR always present with gap more than 7 to 10 millimeter with severe tethering. So that makes imaging more challenging. Okay. So I want to just touch base a little bit because we started using eyes a few years ago, intracardiac echo, to complement or to overcome the limitation of transesophageal echo in terms of imaging of tricuspid valve. So these are the differences in terms of acoustic proximity, anesthesia requirement, grafting resolution,
vascular access, and then cost and workflow. Obviously, 2D eyes, 3D eyes, or even 4D eyes, the costs are much higher. So unfortunately, it's not funded by our government. So patient have to pay from a pocket. And then it also comes with a learning curve for the operator. So the more you do, the more you become slicker in terms of doing it. Okay. So for intracardiac echo, our center is highly selective for patient is able to pay and also a suitable patient. Okay. We have also even done cases with a transesophageal echo together with intracardiac echo. So in terms of pre-procedure assessment goal, we want to look at the TR mechanism and severity. So we want to differentiate whether this is an atrial or ventricular functional tricuspid regurgitation. We need to quantify the EROA, the vena contracta, and the hepatic vein flow reversal. But hepatic vein, usually we get it from a transthoracic echo. And importantly, we need to know the coaptation and leaflet. We have to measure the coaptation gap length, septal leaflet length, more than 9 millimeters is ideal actually for TER. Amount of calcification, the more calcium is it, then the more unsuitable the patient is for triclip. And the presence of pacemaker lead, because pacemaker induced tricuspid regurgitation getting more and more common because we implant more and more devices, and then usually the leaflet, the septal leaflet is splayed open by the lead. So, and acoustic window, we have to determine whether the TE is feasible. Okay, we have to evaluate whether any shadowing from the aortic valve prosthesis. Not uncommonly that we see patients with severe TR, but they already have an aortic valve prosthesis or even a mitral valve prosthesis. Those prostheses will generate a lot of shadowing, acoustic shadowing, and also the thick intra-atrial septum. As the patient previously had rheumatic heart disease, the atrial septum is thickened and fibrous, so that also can cause a bit of acoustic shadowing. So in that case, we probably have to plan the eyes if needed to. Okay, in terms of 3D and 4D eyes, when and how to use. Primary indication, inadequate TE images, acoustic shadowing, high GA risk, severe retroflexion intolerance, and we need to have a secure transfemoral access. So usually it's done by the operator, catheter position in the mid-right atrium, provide exceptional high frequency leaflet resolution. And uncommonly, we also do transgular jugular access, allow the echocardiographer to manipulate the eyes probe from top to the table, leaving femoral space clear operator. Okay, so this is the steps in terms of steering alignment, RA trajectory and height, achieve 2 to 3 millimeter height above the tricuspid annular plane in the right atrium, mid-esophageal 4-chamber view and bicaval view to monitor the distance from IVC and atrial wall to prevent perforation. Step 2 is we have to look at the perpendicularity and clocking, align clip arms strictly perpendicular to the coaptation line, anterior septal and posterior septal. And then 3D enforced wheel or transgastric short axis wheel combined with orthogonal biplane MPR to guide the clip arm opening. So grasping, you have to advance the probe into the RV, lower clip below the leaflet plane during diastole, and verify open arms do not entangle the cord. If you entangle the cord, then there's a very high likely chance that you are unable to proceed with the procedure because you already injured the cord and then the TR become more severe, right? And then grasping wheel, you go in the mid-esophageal dedicated grasping wheel, 120 to 150 degrees. Or if you use eyes, you do a biplane RV inflow outflow wheel. So to confirm leaflet assertion, you have to verify both septal and mural leaflet rest deeply on the arm before a drop of the grippers. Yeah. And then in terms of evaluate TR reduction using color Doppler across the window, you have to use multiplane, mid-esophageal, transgastric, deep transgastric as well. And you have to measure the mean inflow gradient, ensure that it's just 3 to 5 millimeter mercury. And you also have to check the hepatic vein flow conversion from the systolic reversal to forward. And then to examine the secondary TR jets to determine it for putting additional clip. Most of the time, we have to do at least 2 clips, sometimes even 3 clips. Yeah. Okay, this is a step-by-step imaging for tricuspid TER from our lab. Okay, I choose a case that is relatively simple because the images are more echogenic. Some of the cases are really not echogenic and very difficult, took a long time. So usually we start with the mid-esophageal 4-chamber view to look at the septal and also the anterior posterior leaflet R and RV side. and then you move on to the mid-esophageal inflow-outflow commissural view, 50 to 70 degree, to visualize the anterior septal and posterior leaflet in cross-section. Last but not least, after that, you move on to the transgastric short axis view. It's an enforced view of all the leaflet, like a short axis of the aortic valve. You can see all the leaflet, critical for grasping target alignment, so whether you want to clip from the septal to the anterior, septal to the posterior, okay? And then if you want to, you can do a deep transgastric view, which is provide excellent parallel alignment for continuous wave Doppler to measure the gradient. So it's very essential. So you look at the color Dopplers, how much residual tricuspid regurg. After that, you go into the deep transgastric to look at the gradient, see whether it's really caused any tricuspid stenosis. So this is mid-esophageal four-chamber view. You can look at the septal and the anterior leaflet. So you go in deeper, you can get the septal and posterior leaflet. Okay, so to get the tricuspid regurgitation, color Doppler. You can do a mean gradient here from the CW sig. Yeah, so this case, gradient is less than 1. So you get a deep purple, I say septal and septal leaflet and the posterior leaflet. Then you do transgastric, you can get septal on the top, anterior on the bottom, posterior on the side. Yeah. So then there's a tricuspid regurgitation between the leaflet. Then if you want to do a short axis, you can see the anterior leaflet on the right hand side, and then posterior leaflet on the left right hand side, and then the left hand side. Yeah. And three-dimensional, you can reconstruct from the plane. Okay. As you can see, there's a malcoaptation between all the leaflet. Okay, so the good thing about TriClip is we don't need to do a transseptal puncture, so save a lot of time. So we just confine to the right chamber. Okay, so we usually look at the clip arms alignment at the bicable view. Okay, and then you can do an X-plane. You can see where the clip arm is around. Then after that, you can see the clip is actually very well aligned between the leaflet. So this case at 150 degrees view with the X-plane, you can see both leaflets are seated very well on the clip arm. Okay, so open up the color box to look at the color jet. Is it really aligned at the area that you want to clip to reduce the TR? Okay, looks like both clip arm already deployed and then secure the leaflet. And then the TR has been reduced. And then the operator is happy, therefore they release the device. Yeah. And tricuspid regurg has been probably reduced to mild to moderate from severe. Thank you.
Because we have time, so we just want you to share a little bit about the indication for tricuspid clip. And in the case of tricuspid have is functional or primary disease, we prefer clip or just isolated, or in case of other valve disease, do we indicate in this situation? You can, because you have the experience doing this, so you can share. And when you ice, or compare with TE, is it easier for ice in guiding the intervention for tricuspid? Thank you.
Okay, so if you look at the literature, majority of the tricuspid regurgitation is functional, up to 80 to 90%.
Yes.
So not surprisingly, our center, we are doing majority of the cases are functional tricuspid regurgitation. We have done a few cases of pacemakerly induced tricuspid regurgitation. We managed to reduce the regurgitation from torrential maybe to moderately severe or even severe. But the patient functionally much better improved. Less lower limb swelling, less liver congestion. So definitely improve the quality of life, reduce hospitalization. In terms of flail leaflet, I can think of maybe less than 5 cases we've done for flail leaflet or even prolapse leaflet. Okay, so our center experience is mainly functional tricuspid regurgitation. Intracardiac echo is mainly done by my colleague, the structural interventionalist, and at the moment we are only doing 2D eyes. 3D eyes will be probably likely to be started in our program in end of August. I think also in collaboration with Philips. Yeah, but we will probably start with simple cases like PFO, ASD closure, and then move on to appendage closure, and then last is the tricuspid regurgitation. We want to gain a little bit of confidence when we do the intracardiac echo in terms of 3D imaging. Yeah. Okay.
What about abstain disease, the type A or something like this?
We haven't encountered any abstain or being referred to us for tricuspid clipping so far. No.
So for the eyes, who will place the intervention of the echo doctor will place the eyes?
2D eyes is actually done mainly by the structural interventions and Jolie. Yeah. She will be pressing the button to acquire the images. Yeah. But obviously, when we are less busy, we will always join the structural team, even though we just stand beside the machine and then the technician will acquire the images. Yeah.
So in your centers, how many cases you have do both the child clip and mitral clip and child clip at the same time, at the same procedure?
You answer? Yeah.
Very few, but how many? A few, yeah, correct. And most of the time it's sequential, so we clip the do the mitral clip first, and then bring the patient back for tri-clip. But I think there was a patient that did we do concurrent? No, not really, right?
In my experience, I think we only done less than 5. Less than 5.
Yeah, I know of one where we do concurrent.
And both are, all the cases are atrial functional, tricuspid and mitral regurgitation. Yeah.
So after the mitral clip, you had the severe TR, so you wait for treatment and wait for the improvement of the RV first and decide on the treatment.
Yeah, that's
I remember most of the time, almost 90% of the time, we would just do the mitral clip itself, and then we reassess again in a few months' time, see whether the tricuspid regurg has improved, because most of the time it's functional secondary to the severe MR. So if the MR doesn't improve, then we have to maybe discuss with the patient to go for a tri-clip in the next few months. But in terms of doing concurrently, I can remember that there was one severe MR, and then there was one pacemaker-induced TR, then we had to do it concurrently. But procedure took a long time, more than 3 hours. Yeah, a lot of radiation and a lot of contrast, so not that ideal.
What about pulmonary arterial hypertension? When patient with very severe tricuspid regurgitation and cause a lot of symptomatics, do you do tricuspid in that case?
Yeah.
Pulmonary
In fact,
arterial hypertension.
the answer is actually not quite. I think if it's a mild pulmonary hypertension, we could have done some, but we know that the severe pulmonary hypertension itself is a contraindication. So in fact, just 2 days ago on Friday morning, I was running my heart failure clinic, and there was a patient sent to my clinic for candidacy of a tricuspid clip. His was almost massive TR, but his LVEF is 10%.
LVEF.
So I think I sent him for palliative care instead. He doesn't want he's probably not a candidate for LVAD, because if he needs a LVAD, he needs a BiVAD to begin with, because his RV is also significant. So maybe for the audience, I think a lot of times when we assess these cases, it's too late. Yeah.
Too late.
That's right. So it's going to be, you got to select the cases very carefully, and we have, our program has been around for about 2 to 3 years, and we only done a handful. In part is cost, but in part is because many of these patients are pretty sick. RV is too dilated, dysfunction is pretty severe. There's a concomitant left ventricular systolic dysfunction, EF 20%, so we don't do them.
We always have to do right heart catheterizations when we're dealing with right ventricular diseases. So to determine what type of pulmonary hypertension is it, okay? Depends on if it's pulmonary venous hypertension, maybe okay.
The pre-capillary, by and large, we try to avoid.
Pulmonary arterial hypertension, probably contraindicated. We'll ask our pulmonary hypertension specialist to start treatment first. Yeah.
So for the group 2, it's okay. PH for left heart disease, okay.
I think it's fine.
Yes,
yeah.
I agree. So we have a little more change in the program. Now we will have case. So you will try to, because the tricuspid T is very difficult, so we want you to help us to show the case. And here's the case with the, I would like to, Dr. Hùng will present the case.
Vâng, em xin phép báo cáo cây lâm sàng.
You can do the transdorsal first.
Dạ, ca này là một ca đã được phát hiện từ năm 2022, bệnh nhân nam trẻ 22 tuổi. Bệnh nhân này thì trong những cái lần thăm khám từ năm 2022 với giáo sư Lân Hiếu thì đã có những cái phát hiện ra hở van ba lá và mức độ là tăng dần, bởi vì từ năm 2022 là mức độ vừa, đến năm ngoái là siêu âm ở mức độ vừa nhiều, và đến năm nay siêu âm lại thì bản siêu âm tim năm nay là mức độ nhiều. Tuy nhiên là bệnh nhân về cơ năng thì bệnh nhân không đau ngực, không khó thở và đi tái khám thường xuyên. Các cái xét nghiệm thì điện tim thì có hình ảnh sóng quy ở D2 D3 VF, siêu âm tim thì có van ba lá hở nhiều, bùng thất phải giãn nhẹ, chức năng tâm thu thất phải còn bù. Em xin cảm ơn ạ. Mục đích hôm nay làm siêu âm, thầy Hiếu muốn gửi đến để xem là có thể tìm được nguyên nhân hở ba lá cho bệnh nhân hay không ạ?
I think this patient is 22 years old male. He has a Professor Hiếu patient for 3 years. In the past 3 years with tricuspid valve regurgitation. The symptom burden is not much, but the tricuspid is quite moderate to severe, and he's on treatment with a little AC inhibitor, and because here we have a workshop, so we bring the patient here so you can see the anatomy, whether any secondary or primary disease, and any concern about the further treatment because he's very young. Thank you. Yes.
Bây giờ thì cô sẽ làm cái siêu âm đánh giá về các cái tổn thương bên phải thôi. Thế còn các cái gọi là protocol để làm các cái tổn thương bên trái thì buổi sáng cô đã làm rất kỹ rồi, và thời gian thì cũng không còn nhiều. Thì thực ra là các bác sĩ nhà mình thì làm cũng được, nhưng mà mình muốn xem là bác sĩ ở bên Sinh người ta làm như thế nào để mình cũng có cái cơ hội mình xem về cái protocol của người ta khác với mình ra sao. Thế cho mời các anh chị xem theo dõi.
So before
Hello.
we
Yes, okay, we are good.
Okay, so before we go for the transesophageal echo, we'll just do a brief study on the right heart. Let's just take a look at
Yeah.
the function of the right heart as well as the tricuspid regurgitation of the right heart.
Trước khi siêu âm tim qua thực quản, chúng ta sẽ đánh giá qua sơ bộ về thất phải cũng như là mức độ hở van ba lá.
So this is actually just one of our brief echo, like a short study when we do to assess for the right heart function.
Chúng ta chỉ đánh giá sơ bộ qua về chức năng thất phải, kích thước thất phải cũng như là hở van ba lá thôi.
So we will look at the RV inflow.
Mà các đường vào thất phải.
So let's just take a look at the tricuspid regurgitation first.
Chúng ta đánh
And we
giá.
can see that there is some Let's take a continuous wave Doppler. We can estimation of the PASP. It's almost 3 meters for the continuous wave Doppler of the mitral of the tricuspid valve. We'll also just take a pulse wave just to look at the inflow.
Đánh giá pulse siêu âm Doppler xung qua đường vào thất phải.
We can also zoom in onto the valve.
Chúng ta
Look at the structure,
zoom vào để đánh giá cấu trúc.
color, and we can do a PISA.
Đánh giá pizza.
So actually we can see some PISA head over there.
Chúng ta có thể thấy cầu hội tụ.
We go to the short axis. So this is very important because we also looking at the pulmonary pressures. So we want to visualize the pulmonary artery very well.
Và cái này rất là quan trọng vì chúng ta đánh giá cả động mạch phổi nữa, đo kích thước và áp lực động mạch phổi nữa.
And we want to get the Doppler signals.
Để tín hiệu Doppler xung qua động mạch phổi.
So we do a pulse wave at this. We do a pulse wave at the RVOT as well as a continuous wave. So actually we can measure the Doppler slope.
Chúng ta đo Doppler xung và Doppler liên tục qua đường ra thất phải.
And then as always, because we need to do multi-plane, so we will take a look at the tricuspid valve also from the short axis.
Vì chúng ta cần phải đánh giá ở nhiều mặt phẳng khác nhau nên chúng ta đã đánh giá mặt phẳng van ba lá ở mặt cắt trục ngắn.
You can see that the TR velocity here is actually a little bit higher in the short axis as compared to the RV inflow view.
Có thể thấy vận tốc hở van ba lá thì có vẻ cao hơn ở mặt cắt này so với mặt cắt đường vào thất phải chúng ta vừa làm.
So a little bit of angulation is needed in order to see the PISA head.
Chúng ta cần điều chỉnh một chút để có thể thấy được cái cầu hội tụ.
We would generally also just take a look at the LV function just for reporting, and then we will go to the apical views.
Chúng ta đến với các mặt cắt ở mỏm tim để đánh giá chức năng tim, sơ bộ chức năng tim.
So we have the apical four chamber view.
Mặt cắt 4 buồng từ mỏm.
And then we go straight to the right side to take a look at the regurgitation.
Nhìn sang bên phải đánh giá để nhìn hở van ba lá.
We will also do a little short foreshortened view.
Chúng ta dùng các cái mặt cắt không phải mặt cắt chính danh.
If you want, you can also zoom in and
Chúng
try
ta
to acquire the pizza.
chúng ta zoom vào để đánh giá, tìm câu hội tụ.
You might need some angulation in order to get the pizza head to come out, because we know that on the 2D is only two planes, so on one plane, so you only see maybe two leaflets, but the regurgitation might be coming from the other leaflet too.
Chúng ta cần phải điều chỉnh đầu dòng một chút, tại vì cấu trúc ba chiều có thể cái dòng hở nó không xuất phát từ vị trí mặt phẳng này mà xuất phát từ các mặt phẳng khác, cho nên cần phải điều chỉnh một chút.
We will also do a RV focus view. So this will also give us our RV function.
Mặt cắt tập trung thất phải giúp đánh giá chức năng thất phải.
So at every different plane and angle, we will interrogate the tricuspid regurgitation. We want to get the highest velocity in order to calculate your pressures, and we will take a.
Chúng ta cũng đo chênh áp vận tốc tối đa qua van ba lá ở mặt cắt này. Vận tốc tối đa sẽ được dùng để tính áp lực động mạch phổi tâm thu.
We will take a tap C as well as a TDI, tissue Doppler of the RV, of the RV annulus.
Đo tháp C và siêu âm Doppler mô của vòng van ba lá.
And then we will finish this study by looking at the IVC and the hepatic vein.
Và cuối cùng là chúng ta sẽ đánh giá tĩnh mạch chủ dưới và tĩnh mạch gan.
RV volume? We'll also take the hepatic vein.
Đánh giá phổ Doppler và tĩnh mạch gan.
So in the hepatic vein, we'll also see if there's any reversal as an indication of whether the severity of the tricuspid regurgitation.
Chúng ta cố tìm xem có dòng tròng ở tĩnh mạch gan không, do đây là một yếu tố quyết định mức độ hở van.
So I don't see any reversals in the
Ở đây thì chúng ta
hepatic vein.
Không thấy.
And from the color Doppler, it also does not look like it's severe regurgitation. We will see on TE as well. And what do you want in RV volume in 3D?
Sure. The 3D position of the tricuspid valve.
3D acquisition of the tricuspid valve.
We do RV first and then.
Okay, we'll do a RV volume. Oh, you need to use the
để đánh giá thể tích thất phải 3D.
So we usually get a RV focus view.
Chúng ta sẽ dùng mặt cắt tập trung thất phải.
We'll try to also include a little bit of the LV apex, because that is a marker for the 3D dynamic heart model when they put the markers on.
Chúng ta thu hình 3D chúng ta cố gắng lấy một chút phần mỏm thất trái, do đây là cái marker của thất phải nữa.
Out and stop. Hold.
Okay.
Just now focus will, if you want to capture some 3D.
So if you want to do 3D here, you can. You can go to 3D zoom.
Nếu muốn đo 3D thất phải chúng ta có thể dùng tính năng 3D zoom. Okay. Xin lỗi 3D văn bản là
Breathe out and stop hold. Okay.
Oh, you want to drop in?
Yeah.
Okay.
Oh, we can.
Quite close and then drop in.
Yeah. Anything else? Do we all want to show the 3D volume?
No, it's okay.
Yeah. Auto arm.
Yeah, 3D auto.
3D auto arm.
Yes.
So after you have captured the that, then using the 3D, you can use the 3D auto RV also for the volume.
Sau khi thu hình 3D, dữ liệu 3D thất phải chúng ta có thể dùng tính năng Auto 3D để đánh giá vẽ thất phải.
So if usually there is if you need some adjustments, you can always adjust. Otherwise, I think his image is quite good and it's pretty okay.
You get the results.
Yeah. So the global results is over here, but you can also do an analysis. If you need to adjust, you can also adjust these over here using the tracking revision. Yeah.
Nếu chúng ta cần thay đổi, chúng ta có thể thay đổi. Nếu như mà không hài lòng với cái hình ảnh, chúng ta hoàn toàn có thể thay đổi bằng tay ở trên này.
So this will give you like the diastolic volume via 3D, and you can also get some 2D measurements if you need, such as the yeah. And these also can be adjusted if you need. You can also adjust like the tab C if you're unhappy with it.
Bên cạnh là thể tích 3D thất phải thì chúng ta hoàn toàn có thể đánh giá các thông số về 2D ở trên này.
Yeah, so these are some of the adjustments that you can make in case you feel that it's not tracking well. Yeah. Yeah, so I think you can still adjust it a little because you see it's not tracking as well. Look, really want some minor adjustments. Just adjust this a little bit.
Okay, to the TT.
They don't look straight. Oh, okay.
It takes straight. I mean, not take straight. It's a 2D. It's 3D.
Yeah. So
More reliable.
so if you need, you can still adjust a little bit. This one, like if it's not tracking well. So this is tracking okay, but this one can adjust a little bit smaller. Yeah. So you can also adjust the tracking.
This is a primary RV dysfunction. Just now when you went to the 3D tracker speed bar, can you turn on your color?
I didn't get the color in 3D.
Just now you went to 3D.
We went to 3D.
Yeah, and you can go back to the
3D one.
And just when you turn on color, we go back.
You can retake the image.
Yeah, just go. This turn sideways. Yeah.
It's very simple.
Yeah, if it's functional, it tends to be central.
see.
It's closer to the bottom.
Is it functional?
Making
Is it functional? Is it functional?
Looks like functional. Yeah, what- yeah.
No, I think it's not capturing.
Not capturing well. Yeah.
make it bigger. Wide.
Yeah, if you don't capture, you can also do live 3D. If we try this, yeah, we try this. Uh-huh. We turn. Good. Pop the arrow down to the 5 o'clock. Okay, that's fine.
It's already
Okay, turn on your
like that.
color. Turn on the color.
Cannot really see.
No, we only catch the tail, not the
Yeah, you're not capturing.
data control card. Yeah. Okay, no worry. You capture this. Then you come out. Go back to your okay. And turn on your live 3D. Okay, turn on your color.
It's not on the RV focus group. His TR is not not coverage. Got to find the TR.
Yeah, you find the TR first, then we turn on the live 3D.
It's better on the more front view. Yeah. Yes. Okay.
Okay, good. Then we turn on live 3D. Here should be septal anterior. So it's central jet. Central jet.
Is it functional? Main reason is why it's functional.
Difficult to see that.
Okay.
Yeah. So the I think the tricuspid valve morphology it does not look abnormal. But I think what is striking is that even on two-dimensional parameters, although it wasn't specifically mentioned, but during the short axis, you can actually measure the vertical height, and that one looks about 34, 35. So that's already dilated. The short axis, the must be your third frame, I think. The third one, I think number 3, right from the yeah, the cross-sectional diameter. So the Forty. Oh, okay. Yeah, I thought it looks 36. Yeah, 40. So at first I was a bit concerned about ARVC. You have RV remodeling, reduced RV function, and on three-dimensional echo, you can actually see that the normal end diastolic volume for sort of a standard body surface area, this should be about 130 mils at most. We see 100 most of the time, but 130 is, in young men who exercise a lot, 130 is fine, but this one is 211. The 3D RVEF is 34%, so that's reduced. But the 2D parameters, your ThC, otherwise, and fractional area shortening 45%. So those are. So I think there's evidence for RV remodeling, dilation, reduced RV function on 3D echo assessment. I was looking very hard for the ECG changes, so I do not get the not even the minor criteria for ARVC. The tricuspid regurgitation looks central, so I think it's a functional, ventricular functional. So I would think that the other thing that we pick up is that you see a lot of tricuspid regurgitation without pulmonary hypertension. The pulmonary pressures, PSP, is a bit high. We may not have enough PR to do the, I don't think we have, to do the assessment using Mahan's equation. Not much, yeah. So I would think that as what Professor Kong suggests, we will then routinely do a right heart catheterization to want to rule out a pre-capillary. But he's a man, so we have seen, but very uncommon. It tend to be female. Yeah, and then last but not least is to move on to MRI to look for changes. Just the dimension alone, you have one major criteria for ARVC, but we still need the structural, such as the small aneurysm, which I don't see because it's very echogenic. I don't see apical traction on the RV, which suggests otherwise sort of a increase in eccentricity on the RV side. But MRI also can help with the quantitation of the TR. But I think TR is just the egg. I think the chicken is in the RV. Yeah, there's no shunt, right? No. I don't think there's an atrial shunt. Yeah.
So one thing I want to add on to what Professor Raymond Wong commented is, this is truly a ventricular functional tricuspid regurgitation, because the valve coaptate in this position rather than flat. Flat will be atrial functional tricuspid, but this way, so it's a ventricular functional. So, and then the jet is center. Yeah. In terms of severity, Professor Raymond and me, we think that it's probably in the moderate range, because the hepatic vein does not show any reversal. Okay, and then the jet, we eyeball it, we think that is significant but not bad enough to cause severe. So yeah, but we haven't officially quantified with using the PISA volume method. So yeah.
We will do the TOE, and you can guide us to make the 3Ds of the tricuspid valve in this case. And for the concern about the cath and the MRI, we will explain to the family, and maybe we will do in the recent days to find out the cause of tricuspid for the man.
But can I have your thoughts about what's going on here?
Usually, we have seen several patients like this. First of all, we have, like you, we have to rule out any source of intracardiac shunt or outside. Yes, to increase the flow, especially in the young patients without any other comorbidities. So we do TOE. So whether in some case we can find the very low ASD, very close to the IVC or something like this. And sometimes we do the contrast echoes to rule out any pulmonary venous fistula. And like you, we will do the cath, because it's very early and it's not the pulmonary hypertension, but we can find out early. And then MRI, as you mentioned, and in the strict follow-up, whether it increase with time or not.
I just forgot, during the history, was he an athlete?
Bệnh nhân có phải là vận động viên không? I don't think so. Yes, he's just 22.
Yeah, because the people have described now exercise-related ARVC, which is actually a result of the very abnormal adverse remodeling from exercise, and by reducing or actually laying off exercise for 3 months, you can see that the RV morphology actually reversed. I have on my own follow-up a couple of patients. They run half a marathon every week. Yeah, and all they get is a primary RV dilatation and dysfunction, but they're really fit, very bradycardic, and surprisingly, the left ventricle does not show much of the sort of athlete heart changes, but the diastolic dysfunction is normal, and I tend not to get so much tricuspid regurgitation. Mild is common, but not much more. But those are really people who run 10, 15 kilometers every week for years, actually. Yeah.
Okay.
Cho nó rõ. Cầm mic lên cho nó rõ.
You would like to tell us how you do your tricuspid assessment?
Yeah. I would guess some how you comment. Then we can chip in and help. You're doing the... Oh, I see. Okay. Yeah. Okay.
We don't want to change the position of the patient, so we have at the same time 2 sides. The previous doctor is in the left side, and because it's for transthoracic, we use the same side, so the room is small, so we don't need to move the machine. So we try again to do. We usually do on the left ventricle.
Vừa nãy thì ông Dr. Wong ông có nói, tức là trước đây ông có gặp 1-2 trường hợp, tức là các bệnh nhân không phải là bệnh nhân mà tức là cái người mà như kiểu vận động viên ấy, người ta đi người ta chạy marathon thường xuyên, thế một tuần mấy lần, mỗi lần phải gọi là mấy chục km đấy, thì ông cũng thấy có cái tình trạng mà giãn vùng thất phải, trong khi tất cả các cái khác bình thường, không có sân, không có gì cả, áp lực động mạch phổi bình thường, nhưng cũng nói là như thế thì mặc dù buồng thất phải giãn nhưng chức năng thất phải thì bình thường. Thế thì có những một trường hợp ông theo dõi thì sau đấy bệnh nhân đến khi là dừng không tập luyện từ cường độ cao nữa thì sau đấy nó lại đi, nó buồng thất phải nó lại nhỏ lại. Thế thì ông cứ hỏi xem cậu này là có tập ấy không, có gắng xích nhiều không, thế nhưng đúng là bây giờ bệnh nhân đang đặt đầu dò rồi, chúng ta không hỏi được. Lát nữa bệnh nhân tỉnh thì chúng ta sẽ hỏi. Đấy thì tức là khi mà
This is the mid-esophageal, I think, short axis wheel at the 45 degrees. You can see the anterior and posterior leaflet quite clearly here. And then Professor Raymond Wong agrees that the leaflet look a bit redundant, but there's no malcoaptation. The jet is still in the center. Okay.
Đây là mặt cắt trục ngắn ấy. Chúng ta có thể thấy lá trước và lá sau rất là rõ ở đây. Mặc dù lá van thì khá là dài nhưng mà không
It
thể
look
áp van
redundant but doesn't look prolapse here.
Có vẻ không có xa van.
You can do a 3D here. You done already, right? 3D here. Yeah. Color. Explain.
Yeah, it's right in the middle. It's a very central. Yeah. Yeah. Correct. Yeah, this is septal. Yeah, this is septal. Yeah, the septal leaflet. Yeah, we need to take a closer look at the septal leaflet. You see the jet coming through. So, okay, and I just want to make sure it's not primary TR.
Okay, so it's definitely there. And can you turn off your color? But keep the explain on. Keep the explain on just now. Yep, that level. Yeah, okay. Yeah.
There's no
Yeah, yeah.
flare or
No, it's not. Yeah.
I think it's not because I restart. So you're going to finish with the esophageal, then you go into transesophageal. So we usually so at 90 degrees you don't see any problem. We try to get it.
Yeah. Yeah. We should be able to get this very, very ecogenic.
Yep. You want to get this one may be a little bit bigger. Then the anterior here, and then posterior. Yeah, you can do. Yeah, let's look at the anatomy. Oh, okay. So the jack is between the.
Where's your aorta? Your aorta is 1 o'clock, is it?
No, I think it's.
Yeah, you bring your aorta down to 5 o'clock. Would you mind? Yeah. Okay. Then once you bring it up,
Posterior is a smaller one.
so where's the jack coming from?
Septal anterior.
Septal anterior. Yeah, it's a septal anterior. Okay. So we turn off the color on one. Look at that.
Oh, sorry.
No, it's okay.
You get it together.
Yeah. Because you want to make sure there's no primary here.
Yeah.
5 o'clock.
So you always prefer the septum on the 3 o'clock?
Aorta 5 o'clock. Septal will be definitely yeah, always. Yeah. If not, you have to look at. Sometimes your septum is up, sometimes your septum is down. Might as well just always, yeah.
Bit of
Yeah.
drop out, but still okay to see the result of it. So these 3 leaflet are
Are you able to crop into the... When we click face crop, you should be able to bring that plane now.
You can keep this one.
Okay.
Or you can open in 2D and then you can see where you're cropping.
Yeah.
Yeah, so he cropped it.
Oh,
That's
okay.
it. Yeah.
What do you do?
I think it's not stuck. You want to do anything else?
You need to align there's a line there.
Yeah, I'm just concerned the septal looks a bit short.
Do you want to make it bigger?
It looks a bit, the leaflet looks a bit deficient. Usually on 3D, the other way is go to four chamber. Yeah, go 4 chamber view. I just want to make sure that you see the septal looks really deficient,
Short.
very short.
Yeah. And the
Yeah.
anterior looks
So
very long.
yeah,
And a bit restricted also.
this one is
one
is very short.
Yeah.
This is anterior. So you have you have a very short septal. Sorry.
Septal is short.
Yeah, septal is short. So
It's not coming in. It's not coming in.
Is that hypoplastic septal leaflet?
It looks very deficient, yeah, and that's and that's exactly where your that will make it primary, but if you turn on your 3D function over here, zoom, it's very short, really short, correct. It didn't. Oh, I never thought of that because I always do on the left.
But that's why you need to do a transgastric.
But 3D should. Transgastric.
Transgastric.
Okay, we try. The last part. Once you do transgastric, he'll wake up.
Okay.
Yeah.
Transgastric.
Yeah. Anti-flex, good. Yeah, a bit more. Yeah.
This deep transgastric.
Oh, okay. See the septal leaflet here looks okay. No, the septal leaflet looks fine. Once you go, So you're right. Maybe it's because we always do on the left. Yeah, because the heart can tilt this way.
But you can see that the septal leaflet is a bit restricted here.
Yeah. Yeah, but that's right.
Restricted, you see, not as free as the.
That can be because of the free wall.
Yeah.
Once your free wall dilate out, you are tugging onto the so you don't allow free movement. But I just want to make sure it's not hypoplastic.
Can you do a short axis deep transgastric short axis view?
Almost, the last 1 minute, short should be 80 to 90, right? 80 to 90. 90.
You can start with 0 also.
Yeah, but it didn't show.
20 to 60 septal on the top, anterior and posterior.
Yeah, this one is back to the 4. Yeah, we're not deep yet. A bit deeper. Yeah.
Probably have to go in a little bit.
Yeah, it's a bit uncomfortable. Yeah, might have to go just a bit more.
More?
Just a bit more, and bring the angle up to 80. Okay, and then push in. Push in a bit more. Yeah, septal is fine.
Yeah, septal is fine.
Septal is fine. Yeah. It's a free wall, although it's moving, but it's
Patient may be uncomfortable.
Yeah, it's fine. So the septal leaflet is not short. Yeah.
So again,
it's a RV remodeling. Yeah, tugging onto the Atrial septum? Oh, they say they look for shunt.
But only on echo, not on transesophageal.
Oh, you want to shoot the bubble?
No, just angle and put color because certain angle when he turn in certain angle a bit like.
You think there's a
certain angle when he turn.
It doesn't look fast.
bubble study?
Yeah, I guess the last part is just to shoot the agitated saline contrast to rule out the.
You think you can do bubble study? Is that line?
We don't have a three-way. It's okay. Maybe at least maybe just put on the color flow over the. Yeah, you can go to now. Can pull out. Go to back to mid-esophageal 90 degrees.
Mid-esophageal.
90. You just look for color flow. Yeah. I guess shunt being the most common. Yeah. So like what you say, the either the sinus venosus of the IVC, but definitely the sinus okay, so it's quite clear there's no sinus venosus of the IVC, SVC, unroofed CS. They are all quite not there, but the
Thực ra vừa nãy lúc mà trước khi làm siêu âm thực quản ấy, thì cũng có hỏi bác ý là bác nghĩ đến những cái gì thì ngoài cái nguyên nhân bác bảo là do bệnh một người ta vận động nhiều ấy ạ, Thì bác còn nói là cái ca này thì cái chức năng thất phải nó hơi có một số cái chỉ số nó hơi giảm. Thành ra bác bảo cũng chưa loại trừ cái bệnh cơ tim thất phải. Thế do ấy mà gây rối loạn nhịp ấy. Thế thì nhưng mà bệnh nhân này thì không có tiền sử về rối loạn nhịp mà cũng các cái tiêu chuẩn khác về cái bệnh cơ tim thất phải thì nó cũng không rõ ràng. Cho nên bác bảo là thôi thì nếu mà về sau ấy thì bọn mình cũng nên làm cái cộng hưởng từ tim để đánh giá để loại trừ cái bệnh cơ tim thất phải.
For the clip 6. But this because the clip needs to hold the leaflet, so we need the leaflet length to be at least 6 for it to hold. Yeah. No, no. Yeah, it's just that anything shorter than 6, the clip is not able to hold. Yeah. But you can actually see that the coaptation overlap between the septal and the anterior leaflet is almost like one down to the last millimeter. They're just because they're all stretched. Yeah. Yeah. But we've done a PFO closure before, only to find out that patient has sinus venosus of IVC before. So, but this one, no, but this one there's no abnormal flow. Yeah. But if doing the right heart catheterization, you'll be able to see a step up, a step down, a step up. Yeah. So if there's no step up, then you are very, very clear. Yeah.
hypertension proven on right care also. Pulmonary hypertension already seen on right care. So they want to see the transthoracic echo interrogation of the hypertension. Yeah. Only the transthoracic echo. So the usual RBC function can turn on the 3D although as time
Các anh chị vừa mới xem bác sĩ Quân và hai giáo sư làm về cái ca bệnh nhân nam 22 tuổi, và bệnh nhân này thì các bác có comment là xem thứ nhất là bệnh nhân có cái tiền sử là thể dục nhiều hay không, bởi vì đôi khi cái cũng giống như là cái bệnh cơ tim ở vận động viên ấy, thì mình cũng quan tâm bệnh tim trái thì tim phải cũng có thể gây ra những cái giãn thất và hở ba lá. Và trong trường hợp này thì họ đã cố gắng xem và họ không nghĩ đến là một cái nguyên nhân nguyên phát. Tức là lúc đầu thì họ nghĩ là cái lá vách nó hơi bé, nhưng mà sau khi họ đưa tận xuống cái sâu ở dưới dạ dày thì họ thấy là các lá van nó không bị bé, bởi vì có thể là do cắt. Thế nên là không phải là do thiểu sản lá van hay là do xa lá van, mà vẫn nghĩ đến là do thất thải nó gây ra tình trạng hở ba lá đó. Tất nhiên là trong trường hợp này trên lâm sàng chúng ta cũng cần phải loại trừ những cái luồng trong tim. Những cái luồng thông trực viện trên vách nhĩ thì chúng ta có thể nhìn thấy ngay là những cái luồng thông, ví dụ như là thông nhĩ, nhưng mà nó ở cái vị trí sang để cho tĩnh mạch chẳng hạn, thì chúng ta cũng có thể làm xương quản để chúng ta phải loại trừ nó. Còn một số trường hợp chúng ta có thể tim lại âm. Thì hôm nay thì trong cái khuôn khổ thời gian này sự ý trên tim lại âm thì nhưng mà chúng ta đã xem màu hiện tại là không còn cái luồng không của các nhĩ. Đấy thì các bác cũng đề xuất là với trường hợp này cũng tỷ lệ nhỏ, chúng ta vẫn nên thông tin để xem là có cái mức nhảy oxy hay không. Và thứ hai nữa là có cái tăng áp lực truyền qua hai cái không. Sau đó khi đã loại trừ được vấn đề đó rồi, chúng ta có thể tiến hành chụp cái cộng hưởng từ để xem là có cái bệnh lý cơ tim của thất phải hay không, và cũng hỏi cái tiền sử gia đình xem bệnh nhân có những tiền sử bệnh lý cơ tim hay không. Thì đấy là những cái comment ngoài cái vấn đề về hình ảnh của các bác cũng có thể trên cái lâm sàng thì người ta có đưa cho mình một số cái lời khuyên như thế. Thì không biết là các anh chị có hỏi gì thêm về ca này nữa không? Ca này thì họ chưa có biểu hiện lâm sàng, chủ yếu là rõ ràng là một cái thanh niên khỏe mạnh mà hở ba lá vừa như thế là mình cũng phải cân nhắc là vấn đề gì rồi, cũng có lúc mà mình phải bỏ sót và để muộn ấy. Đấy thì đấy là cái mà mình quan tâm. Thế sau đây thì mình còn một ca nữa, thì ca này thì lại là một cái trường hợp mà nữ tăng áp lực về phổi rõ. Thế ca này sẽ vào viện để xét thông tin, và trong cái kế hoạch thì mình sẽ có làm cực quản. Tuy nhiên là vì cái thời gian hạn chế thì cũng sẽ nhờ các bác sẽ làm cái siêu 3D thành ngực của ca này để chúng ta phân tích. Sau đó thì chúng ta sẽ làm cái giải lao, chúng ta sẽ làm cái 3D thành ngực ạ.
Just ask the person. He said that he do the lifting 5 times per week.
Lâu không, mỗi lần lâu.
Next time the lift is about 100 kilograms per time.
Strenuous exercise.
Lifting 5 times per week.
Okay.
Maybe
So,
it affect.
yes,
Or we
definitely.
can advise
3 months.
yeah,
Yeah, enough.
reduce the
Yeah, and then if the dimension becomes smaller, that's it. No need. Maybe don't do right care for now, and no need MRI.
yes.
Stop
So
exercise.
do you think we should do the like the CPAP, cardiopulmonary exercise?
It's inaccurate for him because the normal values, he will overshoot the normal values, and even if he has dysfunction, right? You may get a normal value, but it's already disproportionately low for him. So I think CPAP will.
Super normal.
Yeah, and when it's normal, it could have come from supranormal to normal. So in general, the value is small.
So we just advise the person to change a little bit about exercise. Yeah. Thank you very much.
So you're thinking about athlete's heart. But athlete's heart usually is all the chambers dilated, and then the diastolic dysfunction is supranormal.
100 kg. 100 kg, yeah, correct. It's RV. It's all on RV. Yeah.
Lifting.
Yeah, all the stress on RV, LV as well. Yeah, as opposed to your LV assessment. Yeah, everybody is mainly seen in the LV.
So if we think that there's a precipitant factor, we can try to remove that precipitant factor and avoid the patient doing all these tests first. We have time to wait. But if the patient, despite stopping all these activities and still have this progression, then it's time to do all those invasive tests.
Trước khi mình lấy khỏi bệnh nhân thì bệnh nhân thở và bệnh nhân tập tạng tập tạng 5 lần một tuần. Ngày một tuần. Thế thì chúng ta đi chúng ta có thể cho bệnh nhân tập tạng xuống và họ sẽ có đánh giá lại 3 tháng sau nếu mà mọi thứ nó không thay đổi. Thế thì là mình đi chúng ta từ yếu tố có thể là không thay đổi.
Oh my god, that's bad.
Bởi họ sẽ không thể trình bày cái plan sang về để mọi người theo dõi. Rồi cái trình bày em để ốp vào xương, tự nhiên lại là một bệnh nhân rất nữa. Thì nó có tiền sử phát hiện tăng hấp phổi không rõ chẩn đoán điều trị lắm, nghĩa là chưa rõ. Em khai thác chơi, em chưa thông tin. Thì khoảng tháng nay thì 3 tháng nay bệnh nhân thấy mệt mỏi rất nhiều. Thì đi khám ở bệnh viện Đại học Y thì có xương thì có tăng áp lực mạch phổi nhiều. Tất phải giá cho các con người vào viện lần này để đi tìm nguyên nhân. Thì các cái xét nghiệm thì các cái chỉ số trong giới hạn bình thường THT khoảng 200. Điện tim thì có nhảy hình xoang và tự phải. Siêu âm tim thì có plasma đá thở nhiều và tăng áp lực mạch phổi nhiều. Các phản xạ cho các con rất phải còn phù. Thì rất là rõ. Also do the ASCTs to rule out the very bad the ASCT rule out the any pulmonary infection. No.
You got really nice body shape. I like the boy just now. Was very normal actually.
Yes.
Julie, if you want to discuss another
Very common. We see the young patient with this, and for the first time, maybe dyspnea or some limits in exercise, they come for checking and very high pulmonary pressure. And, in that case, in the hospital, what you follow the flow to diagnose for PAS to rule out step by step?
Yeah, so in fact we have made a couple of this diagnoses in pregnant patients. So they already have these are all pre-capillary hypertension. They were compensating by doing less and less, but they feel okay until they get pregnant. Yeah, so yeah, so it's always very tragic. The baby is just born, but yes,